Hey everyone, so today we're going to read about the basic anatomy and histology of liver along with the mechanism of injury in case of liver. So a healthy adult liver weighs around 1400 to 1600 grams and it has a dual blood supply. So which constitutes the portal vein, which is the first one. It provides the 60 to 70% of hepatic blood flow, and the second one is hepatic artery. So these two supply the liver, and the portal vein and hepatic artery, they enter the inferior aspect of the liver through hilum, or which is also known as porta hepatis. Then within the liver, the branches of the portal vein, hepatic artery and bile duct, they travel in parallel with the portal tracts, which ramify through 10 to 12 orders of branches. Okay, so the most common terminology which is used to describe the hepatic microarchitecture is based on lobular model, which we're gonna see in a while. And this model divides the liver into lobules which are 1 to 2 mm in diameter, that are centered on a terminal tributary of the hepatic vein, and they are demarcated by portal tracts at the periphery. So portal tracts are at the periphery, and in the center there is hepatic vein. Okay, these lobules are often drawn as hexagonal structures, through though the shapes are often variable. It is useful for simplification. A second model divides the liver into triangular acini based on the position of the hepatocytes related to their blood supply. So the hepatocytes in the vicinity of the terminal hepatic vein, they are called centrilobular, which are in the vicinity of the hepatic vein, and those near the portal tract, they are periportal. Okay, so near the portal tract, periportal. Division of the lobular parenchyma into zones is an important concept because each zone differs with respect to its metabolic activity and susceptibility to various forms of hepatic injury. Okay, so if we see in this diagram, we have, this is the model of liver anatomy. In the lobular model, we have the terminal hepatic vein, which is a central hepatic vein at the center of the lobule. Here we have, at the center we have the central hepatic vein, while the portal tracts are at the periphery. As we can see over here, a portal tract made up of portal vein, hepatic artery and bile duct. We have all three things which comprises the portal tract, and these are at the periphery. Here also we have at the periphery, and here also we have at the periphery. Now, pathologists often refer to the regions of the parenchyma surrounding the portal tract and central vein as periportal and centrilobular. So, the region which is around this portal tract will be called as the periportal, whereas the region which is around this vein will be known as centrilobular. Okay, in the SNR model, what happens is, on the basis of blood flow, there are three zones: zone 1, 2 and 3 respectively. The zone 1 is the closest to the blood supply, and zone 3 being the farthest. Okay, so here we have the blood supply and zone 1 which is having the highest blood supply. And what is the significance of dividing this parenchyma into three different zones, we'll see. So within the lobule, the hepatocytes are organized into anastomosing sheaths or plates extending from the portal tract to the terminal hepatic vein. Between the trabecular plates of hepatocytes are the sinusoids. Blood flows through these sinusoids and exits into the terminal hepatic vein through numerous orifices in the vein wall. Then the hepatocytes are bathed by well mixed portal venous blood on one side and hepatic arterial blood on the other side. So the sinusoids are lined by fenestrated endothelium that overlies a perisinusoidal space, which is known as the space of Disse, into which abundant hepatocyte microvilli they protrude. And attached to the luminal face of the sinusoids are scattered Kupffer cells, which are what? These are long-lived tissue macrophages that arise early in the embryogenesis. Another specialized cell type are the hepatic stellate cell, which is found in the space of Disse and has a role in storage of vitamin A between Abutting hepatocytes are bile canaliculi, which are channels 1 to 2 micrometer in diameter that are formed by grooves in the plasma membrane of the adjacent hepatocytes and are separated from the vascular space by tight junctions. So these channels drain successively into the intralobular canals of herring and periportal bile ductules and then finally into the terminal bile ducts within the portal tract. So, this was about the anatomy and the architectural models of the liver. Now, if we talk about the general features of liver disease, so the most important primary disease of the liver are viral hepatitis, alcohol related liver diseases, non alcoholic fatty liver disease, and hepatocellular carcinoma. In this playlist, we have all these features. So, the liver is also frequently damaged secondary to variety of common disorders like heart failure, disseminated cancer and extrahepatic infections. The large functional reserve of liver reduces the clinical impact of mild liver damage, but severe diffuse liver disease can be life threatening. Now, if we talk about the mechanisms of injury and repair, we can see that the injured hepatocytes, they shows potentially reversible changes. So initially there will be reversible changes which can be reversed after the removal of the injury, such as accumulation of the fat, which is known as steatosis, and bilirubin, which is known as cholestasis. When injury is not reversible, then these hepatocytes die by necrosis or apoptosis by irreversible cell injury. So, necrosis is commonly seen following hepatic injury caused by hypoxia and ischemia, and apoptotic cell death predominates in viral, autoimmune, and drug and toxin related hepatitis. Now, widespread death of hepatocyte, what will it cause? It may produce confluent necrosis. This may be seen in acute toxic or ischemic injury or in several chronic viral or autoimmune hepatitis. This confluent necrosis, it begins as a zone of hepatocyte dropout around the central vein. With increasing severity, necrosis breaches central veins and portal tracts or adjacent portal tracts. Now, this regeneration to replace the lost hepatocytes takes place primarily in the mitotic replication of hepatocytes adjacent to those that have died. In more severe forms of acute liver injury, hepatic stem cells, which are located in a niche near the canal of herring, they begin to divide. Now, the differentiating progeny of these tissue stem cells, they produce duct-like structures called ductular reactions, a morphologic marker of stem cell mediated liver regeneration. Okay, so these duct-like structure, which are known as ductular reactions, these are a marker for stem cell mediated liver regeneration. Now, how will we evaluate the liver disease? So, what all tests we are gonna do in case of liver diseases? First one is to test the hepatocyte integrity. What will we measure? We'll measure cytosolic hepatocellular enzymes. What are these enzymes? First one is serum aspartate aminotransferase, which is AST, serum alanine aminotransferase, which is ALT, and serum lactate dehydrogenase, which is LDH. Now, to examine the biliary excretory function, what tests can be done? We'll measure the substances which are normally secreted in bile, like serum bilirubin. We'll measure total bilirubin, both unconjugated plus conjugated, and we'll measure direct bilirubin, in which we measure conjugated bilirubin only. We'll also measure urinary bilirubin, serum bile acids, plasma membrane enzymes, which will be released from damaged bile canaliculae, serum alkaline phosphatase, and serum gamma glutamyl transpeptidase GGT. Now, for hepatocyte synthetic function evaluation, what all tests we can do? We can measure proteins secreted into the blood, which are serum albumin, coagulation factors. We can do tests for PT and APTT, and for hepatocyte metabolism, we can measure serum ammonia and amino pyrene breath test, which is due to hepatic demethylation. Okay, so these all tests can be done. In this photomicrograph also we can see hepatocyte necrosis. So this stain is periodic acid shift Pas D stain. This biopsy shows clusters of pigmented hepatocytes, as we can see over here, pigmented hepatocytes with eosinophilic cytoplasm. So these indicate what? Hepatocytes undergoing necrosis. Okay. Now, scar formation may follow severe acute injury but occurs more often as a reaction to chronic injury. When there is a severe injury that causes death of large number of hepatocytes and the dropout of liver cells, the underlying reticulin may collapse, precluding orderly regeneration of hepatocytes and laying down of collagen. So in this photomicrograph we can see the above one, we have seen the necrosis, and in here we can see this hepatocyte apoptosis. Okay, so we can see scattered hepatocytes which are apoptotic, and they have a patchy inflammatory infiltrate also. We have inflammatory infiltrate and we have apoptotic hepatocytes here. Now, the principal cell type involved in scar formation is the perisinusoidal hepatic stellate cell. So what these cells do, these cells become activated and are converted into highly fibrinogenic myofibroblasts which lay down the fibrous septa. Eventually, these fibrous septa encircle surviving regenerating hepatocytes in late stage chronic liver disease, giving rise to cirrhosis. Now, inflammation and immunological reactions are involved in many forms of liver diseases. So, the systemic inflammation alters the metabolic and biosynthetic activities of the liver, leading to increased secretion of acute phase reactants such as CRP, serum amyloid A protein, which is a precursor of some form of amyloid, and hepcidin, which is a key regulator of iron metabolism. As we'll discuss, adaptive immune cells play a critical role in viral hepatitis, with CD4 plus and CD8 plus T cells being particularly important in eradication of virus infected hepatocytes and in causing liver injury in chronic diseases. So we have seen the basic architecture of the liver and the mechanism of liver injury. It could be reversible or it could be irreversible. In case of reversible injury, there will be steatosis, cholestasis, and in case of irreversible, there will be necrosis and apoptosis. So what all things will be done? We have seen that how can we measure and how can we evaluate the liver disease, what all tests we can do. So we have seen this. Okay, thank you so much.